Thanks, everyone. I guess I am the last speaker before we start what I imagine will be a really interesting set of questions and discussions. I want to thank the organizers for allowing me to fill you in a short time about what we're doing at North Shore LIJ's health system to bring together these three important initiatives. Just a little bit about North Shore LIJ, which will soon be known as Northwell Health. We're undergoing an enormous branding and name change. We are the 14th largest healthcare system in the United States and the largest private employer in New York State. We service 8 million people all out Long Island, the 5 boroughs of New York City, and now into Westchester. As of last week, we have about 62,000 employees, 10,000 physicians, 11,000 nurses. We have the first allopathic new medical school in New York State in 40 years. And what I found fascinating about this morning's discussion is about where we start the education so that this becomes embedded in everything that a new physician learns. And if you can look something up on a small handheld device, you should no longer be spending time in medical school learning this or wasting a memory bite. So instead, our school actually starts in the first 12 weeks by putting our medical students riding the ambulances with EMS. And if you want to learn about social determinants of health, drive in an ambulance to an underserved neighborhood at 2 in the morning and walk into that home, and there'll be no doubt why adherence to medications is an impossibility in some of the environments that these students visit. We've also just now opened a nursing school for advanced nurse practitioners and ultimately for bachelors as well that really turns education on its head. Our Center for Learning and Innovation is the largest corporate university in healthcare in the country, and we also have the nation's largest patient simulation center. By way of footprint, this is us. I've been out of the office for a few days, but I think we are now 20 hospitals up from northern Westchester throughout the 5 boroughs of New York City and all the way out to eastern Long Island. We have well over 400 traditional ambulatory practices, as well as significant inroads in healthcare, home care, long-term care, as well as hospice care. In New York City, we've opened an interesting state-of-the-art complex down in Greenwich Village called Lenox Health, which really is a new model of community-based clinical practice, as well as the first freestanding emergency department in New York. So now you know how big we are, but this is a little bit into how complex we are. Although we span a very large geographic area, we have become extremely diverse. In Queens alone, which is one of the 5 boroughs of New York City, on any given day you'll hear 175 languages spoken. Until the new acquisition of 2 predominantly white community-based hospitals up in northern Westchester, greater than 40% of our covered lives do not speak English as the primary language at home, about double the national statistics for this. So to that end, because of the changing demographics, at our health system, we felt that this opening an office of diversity, inclusion, health literacy really supported the business case. And there's been a lot of discussion about business case and return on investment. And I think, in fact, you do have to align that with doing the right thing. But when margins get smaller and competing needs become an apparent financial concern, the business case is very important. So in 2010, our Office of Diversity, Inclusion, and Health Literacy was created with the mission to promote, sustain, and advance an environment that supports principles of equity, diversity, inclusion, health literacy, and community. This office was started by Dr. Parnell, Dr. Merez, and their colleagues Fallon Williams, who could not join me today. And since then, a lot of changes have happened, and it's been a fascinating journey, actually. When the office was first launched in 2010, it was begun with a multi-year strategic plan to establish goals and steps to further embed a culture of DIHL across a complex health system, which included medical students, several thousands GME, as well as the surrounding communities. First, to get a feel of where we were in 2010, the office performed the AMA's Community Climate Assessment Tool Kit survey at several of our hospitals to better understand these hospitals' cultural competency and health literacy awareness and readiness. Based on the findings of this initial study, our strategic plan was established. The plan initially focused on education and awareness, and quite frankly, in 2010, the specific matters of diversity and inclusion and health literacy were somewhat siloed. Health literacy efforts were predominantly focused on education and awareness in several of our larger hospitals, and diversity and inclusion and health literacy activities were embedded in the new medical school curriculum. You've seen this before, but simultaneous with our efforts in 2010, in June 2011, the U.S. Department of Health and Human Services announced the nation's new national prevention strategy under Dr. Regina Benjamin. This focused, as you can see in the center, on increasing the numbers of Americans who are healthy at every stage of life. Drawing on the current landscape of healthcare reform and aligning with the national prevention strategies, we felt that our office, DIHL, should really align with two of these important four strategic initiatives. It's funny to have to even go through these, but allow me for a moment. Empowered people, it's clear to all of us that health information is presented in a way that most Americans will find difficult, and all Americans will find difficult at some time in their interaction with healthcare. When individuals have access to actionable and easy to understand information, they are empowered to make healthier choices. And of course, we know some of these that we embedded into all forms of patient education in our health system, plain language, teach back, and really empowering our communities and individuals to participate in healthcare protection or primary prevention opportunities. The elimination of health disparities. Obviously, we know that health outcomes vary widely based on race, ethnicity, socioeconomic status, and other factors. The social determinants of health are important and can seem overwhelming, but the importance of prioritizing this within our office was key. And it became a focus of our ensuring strategically that we identified community as at risk, brought in community leaders, members, and organizations to be sure that any new programs that we were creating or any opportunities to partner with our community were done in a way that really aligned with local culture and appreciated the uniqueness of the vast communities that we serve. So it became clear to us by 2011 that we needed to expand our diversity, inclusion, and health literacy office. And by 2011, we brought language access services as well as cultural competency activities into what was originally an office focused almost in silos on diversity, inclusion, and health literacy. And what you see in gold, those cogs clearly needed to be aligned in one focused strategic effort to ultimately lead to better patient outcomes through overlap with professional education, governance, research, and patient care. So what we felt, in other words, at this time, by 2012, 2013, is that we really needed to refocus our efforts to improve the interaction between an individual's ability to access healthcare and the demands of the healthcare system that we worked in. With the addition of language access services and using the National Preventive Strategy as a guide, the Office of DIHL developed an expanded strategy that included language access, traditional health literacy activities, and cultural competency, now all under the guise of effective communication. So to see the way we evolved since 2010, initially we formalized our activities focused on awareness and education after using our toolkit to see where we were at that point. Quite honestly, diversity and inclusion and health literacy activities were somewhat siloed. In 2011 to 2012, we developed the opportunity for health literacy to become centralized in the DIHL office. All materials were evaluated through our office. We went system-wide with education and raised awareness activities, but predominantly our model was to bring all of these patient education, written materials into our office. In 2013 and 2015, again focusing on the two initiatives from the NPS as a guide, we expanded our diversity, inclusion, health literacy to focus explicitly on cultural competency and language access as well. And finally, because we realized that empowering our communities to become active members in their healthcare, we found in our very large, complex system, it became imperative to empower our employees to become involved. And from 2013 on, we started to decentralize many of our activities so that instead of things coming in toward the DIHL office, things were partnering with our facilities-based experts to be sure that not only were they empowered to do right by their individual communities and their complex clinical needs in their areas, but that they felt that this was something that they actually could become part of. Because our community is very large and the way we train our employees and bring out our activities was very complex, we were sure to use many different modalities to educate our employees about topics and allow our employees to educate and involve our patients. We used courses and conferences, some of which were digital, some of which were part of onboarding. Mandatory topics were now embedded with all the principles of LLC and what was originally for us DINHL. Our vital document standardization has become critical and important, and our community outreach with partners has also allowed us to decentralize this role. Later in 2013, the Office of Diversity, Inclusion, and Health Literacy became a division in the Office of Community and Public Health. As you can see, this office included public health initiatives. Our community benefit and CBEC activities are done here, and the Katz Institute for Women's Health, where I work, sits here as well. The Katz Institute, for instance, is based on 4 pillars that were originally supported by the NIH activities in the 90s on women's health. One of them is education and health literacy. And for us, it became a guiding principle that all our community initiatives, our events, our fact sheets, our presentation, all of our Katz Institute for Women's Health activities went under the guise and the tenets of health literacy, cultural competency, and language access. The Long Island Regional Adult Education Network oversees approximately 80 literacy sites throughout Long Island, and they were DIHL's first community partner. Our staff taught a course called the ABCs of Health Literacy, which allowed their educators to incorporate health literacy tenets into the classes that are taught at their health literacy centers. In 2014, we had a health system-wide book drive with 14 drop-off sites and donated over 4,000 books that were used throughout literacy programs in the New York area. Our public health initiative established a partnership with an underserved community in our area, Spinney Hill, where we started with somewhat traditional opportunities to engage this community in health literacy and some prevention strategies. And we learned quite a bit about cultural competency in an area that we thought we knew quite a bit about. And instead, we learned the importance, or relearned, or refocused our initiatives on really bringing the community members as a very important partner with us for these initiatives. The commitment at leadership is critical. Without it, you can't embed these kind of important and not initial, easily to define ROI. There is an executive DIHL council, which is chaired by our CEO and president. There is a physician leadership group, which is chaired by our chief medical officer and the chair of the Department of Medicine. We have a system committee into which our language access group is being driven, as well as at each of our important sites, at least the 20 hospitals and some of our larger ambulatory practices, site-wide committees that, again, work in a spoke and hub process. Our work has not gone unnoticed, whether in the LGBT healthcare, for Diversity, Inc., as well as for some innovation awards that we've received. Now turning to New York State, and I guess some other states, our ability to expand our health literacy strategy has been recognized through the DSRIP activities. In April of 2014, New York State and CMS finalized an agreement to develop a delivery system, reform incentive payment, or DSRIP program. These programs promote community-level collaborations and focus on sustainable system reform. Our health system is actually leading the health literacy, cultural and linguistic competency activities for the New York State DSRIP activities on Long Island. And we're proud of this, and it shows that our ability to bring initially siloed activities into one is really going to have an impact on the communities that we serve. Finally, just a week ago, North Shore LIJ was the first large health system in the New York State tri-state area to take the pledge to eliminate healthcare disparities through the American Hospitals Association. And even though these are somewhat aggressive expectations, we gladly signed on as our CEO thought this was important. We hope to make progress in 3 areas. These are aggressive expectations and aggressive timelines that provide the greatest opportunities for us to increase equity of care. to increase the collection and use of race, ethnicity, and language preference data. It should be so simple, but Long Island Jewish Hospital, where I do most of my clinical work, sits on the cusp between Queens with 175 languages and Nassau County. And when we last looked, 90% of our population is still listed as white and English speaking, and we know that's just dead wrong. So there's clearly, even in something that should be so simple, an opportunity to do this much better, and we all know the data is critical. To increase cultural competency training, and we expect to do this in a similar multidisciplinary fashion to how we addressed health literacy issues in 2010. And lastly, to increase diversity in leadership and governance, a really critical and repeatedly shown important feature of a health equitable system. Just as a quick review, though the zero went up, you can see that we began with focused efforts on education and awareness. We expanded and brought language access and cultural competency in. We developed an expanded model next, focused on the national prevention strategies and exporting the data so that not only were our communities empowered, but our employees were empowered. And finally, really focusing on how to advance effective communication in a state, New York State, as well as on a nationwide level. Thanks very much.